Awesome. Good afternoon. I'm going to just give us a minute and start by welcoming you to both our audience here in person as well as those joining us virtually on Zoom to Global Equity and Access to Pandemic Response Tools, the third semi-annual seminar from Boston University's Center on Emerging Infectious Diseases, or CEID. I'm Bhadelia. I'm an infectious diseases physician, and I'm the director of the center, and I'm an associate professor at the BU School of Medicine. CEID is a multidisciplinary university-wide research center which focuses on public health, policy research, capacity strengthening, training, and advocacy. Our faculty come from across 9 Boston University schools and colleges and over 25 departments, as well as from institutions from around the world and across the US, joining together for one purpose: building resilience against new epidemic threats. Just as the problems are complicated, we feel the solutions need to be multidisciplinary. Today's event is part of a semi-annual seminar series that links public health and policy experts with all of you for discussions on lessons learned and challenges and opportunities ahead. Today's seminar focuses specifically on how we mindfully and consistently make equity not just part of the principles, but also the operational guide to how we move forward in manifesting the best possible pandemic preparedness and response. So as someone who's been a frontline responder to a lot of outbreaks, I can tell you that maybe I'm wrong on this, but more people die in the world from a lack of access to things that already exist than from a lack of resources that have not yet been invented or discovered. And it's not that innovation is not important, it's simply that innovation alone without accessibility doesn't help us recognize the true benefit of that innovation. About 10 years ago, almost to a month, and I remember this story partly because I knew Joia was going to be one of the speakers today with Partners in Health. I was in a classroom with Ebola survivors during the West African Ebola epidemic, and they were getting trained to go back to work in Ebola treatment units on infection control. And I got through my slide about Ebola and the history of Ebola, and I remember this very young man putting his hand up and saying, "Wait, you've known about this disease since 1976, and you still don't have a treatment?" Right? So for me, true global equity in pandemic preparedness goes beyond just benefit sharing and sample sharing, which are critical, don't get me wrong, but it is not enough. Equity is also defined in how we collaborate in setting up research agendas, in who does the research, what diseases we invest in addressing, how we shape the tools we develop to better serve different environments. Equity is in how we define successes when new outbreaks appear. When one life lost, regardless of where it is lost, is just as valuable and just as tragic. So I waited to write these remarks until yesterday, because I figured things may change depending on the results of Tuesday. And it may affect the way the global community plans for the next 4 years. And I think regardless of what the administration had been, elections are a way for us to reflect what we will invest in as a society moving forward. For us here at CEID, this event marks, again, a re-underscoring of the fact that global equity is going to be one of the basic things that we continue to principally integrate into all our programs and principles at CEID. With that, just a word about the format for today. I'm going to be your MC for the course of the event. Very soon I'm going to turn over the podium to President Melissa Gilliam for brief remarks, and then we'll have a moderated panel followed by a keynote address by Assistant Secretary of Global Affairs at the Department of Health and Human Services, Ms. Loyce. The day will end with a networking reception. We're broadcasting live, as I mentioned, both over Zoom as well as here in person. And we will be keeping an eye on the Q&A in the virtual chat. So if you have questions, put those in there, and we'll try to share that with the panelists as well. So let me take this opportunity to introduce just a historic inauguration that we just had with this incredible leader who's now taken over Boston University and its future directions. And huge shoes to fill, of course, from Dr. Bob Brown, who's also joining us today, the President Emeritus of Boston University. So Dr. Gilliam is an esteemed and award-winning interdisciplinary researcher in medicine, public health, and the humanities. Dr. Gilliam joined Boston University from Ohio State University, where she served as the Executive Vice President and Provost. Her scholarship focuses on developing innovative biomedical interventions to promote adolescent health and well-being. Dr. Gilliam is a member of the National Academy of Medicine, American Gynecological Club, American Gynecological and Obstetrician Society. Among her many awards and honors, she received the King Arts Center Legacy Award in 2022, and was named a Centennial Scholar of the Institute of Medicine in Chicago, received the Chicago Urban League Innovator Award, the US FDA's Advisory Committee Service Award, Chicago Foundation for Women Impact Award. She has published over 100 articles in her field, and she's earned her Bachelor's of Arts in English Literature from Yale University, a Master's of Arts in Philosophy and Politics from the University of Oxford, and a Doctor of Medicine from Harvard University, and a Master of Public Health from University of Illinois, Chicago. She completed an internship in general surgery at the University of Chicago and her residency in OBGYN at Northwestern University. Without further ado, President Gilliam.
Thank you so much for that warm introduction. It's wonderful to see you all. Thank you all so much for being here. So, a special thank you to our panelists, Hillary Carter, Joia Mukherjee, and Andrea Vicari, and to our keynote speaker, Loyce. It's really nice to have had a minute to meet all of you. And thank you so much for lending your expertise to us here at Boston University. And I'd like to thank Dr. Bhadelia for her welcome and for inviting me to speak to you for a few minutes, and also for just your incredible leadership of the Center for Emerging and Infectious Diseases. What you are doing here at CEID is so important, and it's such a reflection of BU's commitment to supporting projects that positively impact the world. This center is tackling the threat of emerging epidemic infectious diseases worldwide, and it's doing it so in such an innovative and cross-disciplinary way. As you heard, a few weeks ago, I was inaugurated, and at that time, I pulled up and I lifted up this idea of how important it is and how well we do interdisciplinary research at Boston University, and it's a topic that we've discussed a lot, and with Provost Waters, we've really talked about Boston University being uniquely positioned for convergent research. And I'm so confident of our ability to do this at this institution because of leadership from organizations and centers such as CEID. And so we have this idea, this possibility of integrating our campuses, our colleges, our schools, our knowledge, our tools, our ways of working, our ways of thinking, and using from disparate disciplines, bringing those together to really transform the way that we are thinking, the way we're creating new frameworks, and the way that we are reimagining projects and problems. And so the center is really, as you heard, leading the way. The faculty represent 9 of our schools and colleges, and then also includes external and international affiliates. And you all, who are now partners of the center, you bring so much expertise from so many different fields. I know that your other semi-annual symposia were predominantly domestic, and so this is a really exciting moment also to think about the issues of emerging infectious diseases in the global context. We know that the problems of the world continue to become increasingly more interconnected. They are more global. And so the idea of how we are able to collaborate in effective ways to address global pandemics is really essential. I think it is clear to all of us following the COVID-19 pandemic. I think we all understand the importance of understanding emergent infectious diseases. In my own experience, it was February of 2020, and I had just, I was working on a research project that ran directly into the pandemic. And I was in the midst of preparing to conduct a study. I'd spent about 5 years working very closely with populations in Uttar Pradesh, India, and I was focused on the issue of girls and education as this lost population that really had not met the full benefits or received the full benefits of attending school. And so I had spent so much time developing the intervention, and really, as you were speaking about equitable approaches, I felt like that was such a hallmark of the way that we were working, with each part painstakingly piloting each element of our intervention, co-creating with young people. And we were just about to go into the field when the pandemic struck, and the whole project, which was really going to be scaled across rural schools, was interrupted. And so it really brought home to me this idea of the intersection and the synergistic intersection between poverty and poor transportation and infectious diseases and pandemics. And while we saw many, many people who were away from school, and we're all experiencing and seeing the learning gaps that resulted from the pandemic, when I think about rural communities and communities that face multiple inequities, thinking about how we think about emerging infectious diseases for these populations is so critically important. And so that's why I'm so excited about the work that you will do today and the things that you will consider today. So my project was about gender inequality, and just thinking about the remarks and thinking a little bit about what you would do today. Again, you can think about how the problems you're addressing and thinking about further inequalities. And so again, that's why it's so important that collectively we start to think about these issues and we think about them in a global way. And the work that CEID is doing is already so significant, but through public health and policy and research and capacity strengthening, training and advocacy, you'll only get better. So moving forward, I'm hopeful that we can continue to establish the Boston community, Boston University, all of your collaborators, and empower all of you all and all that you do to better address pandemics, emerging infectious diseases, other outbreaks in an equitable way. And I'm just so grateful for your leadership and the way that you're thinking about the multiple systems that affect people's lives and populations and communities. So thank you all so much for being here. I'm so excited about what you will discover today, and the collaborations that you will create, and what will come out of the work that you do together today. And so thank you so much for being here, and I just wish you a wonderful, wonderful afternoon. Thank you. Thank you. I'm so happy to be here.
So I am going to bring our panelists up, and as you're sitting down, I'm going to introduce all three of you. Dr. Joia Mukherjee is a physician, educator, and activist trained in infectious diseases, internal medicine, pediatrics, and public health. Since 2000, she has served as a chief medical officer in Partners in Health, an international medical organization program based in Haiti, Rwanda, Lesotho, Malawi, Sierra Leone, Liberia, Peru, Mexico, Russia, Kazakhstan, and the Navajo Nation, and now in cities and states across the United States. Dr. Mukherjee coordinates and supports PAH's efforts to provide high-quality, comprehensive health care to the poorest and most vulnerable. She's an associate professor at the Division of Global Health Equity at the Brigham and Women's Hospital and in the Department of Global Health and Social Medicine at Harvard Medical School. She's also on faculty at University of Global Health Equity in Rwanda, Joia teaches infectious diseases, global health delivery, human rights to health professionals and students from around the world, and directs a master's degree program in global health delivery at Harvard Medical School. Dr. Andrea Vicari is chief of the Infectious Hazard Management Unit at PAHO, Pan American Health Organization, and the Regional Office of Americas for WHO. In this role, he leads the work of PAHO's emergency program to strengthen member states' capacities to prevent, prepare for, and respond to high-threat pathogens of known and emerging pandemic and epidemic potentials, such as influenza viruses, coronaviruses, yellow fever, arboviruses, hemorrhagic fevers, cholera, plague, leptospirosis. This work includes developing and establishing pan and epidemic preparedness plans, epidemiological, virological, and genomic surveillance systems, laboratory and reference diagnostics services, their networking, biosafety, biosecurity, and clinical management and infection control. Within PAHO's One Health approach, he leads the efforts to reduce risks from emerging and re-emerging zoonotic and epidemics and pandemics. I'm going to shorten this, but I do want to mention there is a QRS. So if you feel like I'm droning on forever, but you're missing the details, just use your phone to do the QRS, and you'll know exactly who all of our speakers are. Dr. Vicari has 20 years of experience at PAHO and is, with assignments at the country, regional, and global levels. He advised the Colombian health authorities in response to H5N1, facilitated the uptake of human papillomavirus vaccines across the Americas, and led and implemented pivotal Ebola vaccine trials in Guinea. And then, here we go. And Dr. Hillary Carter, last but not least, serves as the Senior Strategist for Global Health Security in the Bureau of Global Health Security and Diplomacy at the State Department. In this role, Dr. Carter served as the Acting Principal Deputy Coordinator for Global Health Security, where she helped set the strategic vision for State Department's new bureau and launched the Foreign Ministry Channel for Health Security. She's held leadership roles at the White House National Security Council, wonderful colleague to work in when I was at the White House as well, an incredible person to learn from. And at the Department of Homeland Security, where she drove policy actions to strengthen global equity, global health security, respond to infectious diseases threats, counter biological, chemical, radiological, and nuclear weapons. During her White House tenure, she led the development of the first U.S. Global Health Security Strategy and the 2019 National Biodefense Strategy, which she helped revise in 2022. She is not just a policymaker, she's also a PhD in cell and development biology from Vanderbilt and a Q Executive Leadership Certificate from American University. Can I have you guys come on over? Am I live? Okay. I thought we were going to spend the whole afternoon me reading these incredible bios, but I'm glad we're on this side of it. I want to start with a prompt, and I want you to take that wherever you want to go. Take 5 minutes each, and then what I might do is just come back and ask a few more questions. How does equity translate for you when we start talking about pandemic preparedness, and do you think we've gotten closer to that vision after, or farther away after the COVID-19 pandemic? Andrea, I'll have you go first.
No, thank you very much. First of all, it's so nice to be here today. Really, it's a great pleasure, to be here and to be able as well to share with many of you, these considerations. When I was preparing for today, I had to go back and look, what is the definition of health equity for WHO, because there is a definition, no? And I think one important part of it is really that it deals with differences that are unjust and preventable. No? And I think it's kind of interesting because there are these two components. One is the unjust, I think, really relates to the Charter of the United Nations that leads as well to humanitarian law, if you want, or what is really the humanitarian component, of the United Nations. But at the same time, there is this idea of what is preventable, and in my mind, to some sense, it's a little bit of a contradiction because, what is not preventable to some sense, when we are talking about inequities. And for our region, we need to recognize that the region of the America, in particular Latin America and the Caribbean, is the most inequitative region of the world, And I think we have seen that definitely with the COVID-19 pandemic, and then we have seen it again with the Mpox as well, outbreak in 2022. No? And so, why is it, that we have been so affected, by these emerging threats? One idea could definitely be that we may have a better surveillance system, maybe we are as well more open in the way we share the information. But maybe it's as well how the society has worked and the way people interrelate as well. But it's as well too that it can really be at the base definitely some important inequities, and we know that with infectious diseases, whether it is social, whether it is economic, whether it is environmental inequities, determinants, they will reflect in the end in terms of what we are seeing. So I think, it's really important as well to consider that concept. So what has changed, since the COVID-19 pandemic? I think one important part is really this idea of you may have seen that there is this international negotiating body that they have been discussing about a global pandemic agreement. No? And I think this is definitely a great opportunity in terms of making a difference from before the COVID-19 pandemic and not. Unfortunately, this accord was due to the World Health Assembly in May of this year. There are some pending issues. And some of the pending issues are really very important. Now, one is really the issue of pathogen access and benefit sharing. That to me, it's key in terms of really reducing inequity in particular to access to medical control measures. And the other part is these ideas that was a lot discussed in terms of the co-development and transfer of technologies. No? And so I think that's another very important concept, that will be kind of put into these pandemic accords. That would be a great opportunity. And hopefully, it will still come, either, not maybe this month, but, in the next 6 months when there is the next deadline. So, but at the same time, what we have been seeing is definitely as well several regional initiatives, in terms especially related to the production of messenger RNA vaccines. One in South Africa for the African region, one as well that we are supporting in Latin America, in particular Argentina, Brazil, for really the development and production of as well this wonderful technology, if you want. So, I think there are some good things going on. There are some other things that that they are still in a potential phase, but hopefully we can as well move forward. So it's an uneven progress, I would say.
So slow progress, some progress. Yes. Potential for more in the future.
Definitely.
Yeah, thanks, Nahid. And I agree with what you've said, and that was really helpful. I mean, the Latin America region does have very stark inequality, and I think we saw that with COVID in places like Brazil, but we also saw it in the United States. And I think, when I think of equity, I always think of the fact that zip code determines whether you live or die much more than any pathogen. And that's true everywhere in the world. If you just take the train 6 minutes from Roxbury Crossing to Back Bay Station, the life expectancy drops 20 years. And that's not about behaviors, it's not about pathogens, it's about deep and systemic inequality that is baked into so many places in our society and in our world. And I think when people asked me during COVID, why is the United States doing so poorly? The month before COVID was announced as a public health epidemic of international concern, there was a ranking that came out of Johns Hopkins University with the Economist Intelligence Unit and then the Nuclear Threat Institute about preparedness, global preparedness. And number one in that ranking was the United States. Down in the bottom area was Rwanda. There's almost no country that performed better than Rwanda in the COVID-19 pandemic, and that is in part because they have a serious focus on equity. Serious focus on equity. I was privileged to work in the United States for the first time in a long while during COVID-19. I got to work with my friends at the Department of Public Health and elsewhere, and just saw the inequities that we are dealing with all the time. So when I think about equity, I agree, going back to that definition of justice and the preventable nature, but we think of at Partners in Health, and certainly teach this to our medical students, that really these social determinants of health, which I don't like to actually call them determinants of health, I really think of them as forces. The social forces that are pushing against ill health are largely there from historical choice, from current day policy choices, and that we as people who care about equity and fairness actually have to push back against those forces. And so as we think about equity, what does that mean? So just a small example from Massachusetts, Partners in Health helped the Department of Public Health and others to do contact tracing. It was all virtual. We called 300,000 households before the end of the pandemic. And we would say, you're a contact, these are the things you need to do, and not share a bathroom, do this, not go grocery shopping, etc. But the equity proposition was to say, can you do that? And if the answer is no, then you gotta do stuff to fix it, right? And that's what it means. And I loved your comments, Dr. Gilliam, because I think thinking of whether it's education, transportation, whether it's food security, we found ourselves delivering diapers to families so that the mom could stay in quarantine when she had a small child. This is the equity proposition. And so as we think of pandemic preparedness, health system preparedness, we have to look at this differential outcome and how do we then mitigate the social forces that make things unequal. And I think it's often the same things: transportation, food, getting paid for work. These social and economic rights that people are lacking in a very systemic way across the world, that has to be part of our package for pandemic response and preparedness. Because if the inequity stays, the pandemic, infectious diseases find the fault lines of society. We see it over and over again, whether it's AIDS, TB, COVID, Mpox. Infectious disease is very smart, it will find the cracks. And so we have to seal up those cracks. We have to keep working vigilantly before, during, and after pandemics to address inequality.
Yeah, it's notable because about half the world doesn't have access to primary care, right? About 40-something%, 48% was the number the Lancet Diagnostics Commission had in terms of access to diagnostics for top 10 infectious diseases or diseases of concern. So certainly we can't meet any 100-day missions if the clock is delayed depending on where the disease is. Hillary.
Yeah, thank you, Nahid. And thanks to you and your center for convening this really important forum. It's a pleasure to be here, particularly with Andrea and Joia and you. And you were also a fantastic colleague and at the White House, really enjoyed that time together. So I'm going to come at this from maybe the strategic level, kind of the 50,000-foot level. Hopefully we'll complement the comments, the really great comments that you've heard already. So, and I appreciate the focus on definition for equity and pandemic preparedness. I think that's really important. And when you think about this from the US government perspective, I think equity and pandemic preparedness is really well stated in our global health security strategy and the vision statement in there that says, which is a world where all people are protected from health security threats, particularly those posed by infectious diseases, with emphasis on all people. And as Nahid said, I'm at the State Department, the Bureau of Global Health Security and Diplomacy. And so our role there, working with others, including Assistant Secretary Pace, is to promote international cooperation, to stimulate action so that we can protect Americans, we can protect people around the world from health security threats, including HIV/AIDS, which I'll talk a bit more about in the President's Emergency Plan for AIDS Relief as we get into the conversation. So practically speaking then, translating that kind of high-level vision statement or statements to the practical world, a commitment to equity from the U.S. government's perspective is really a commitment to addressing those barriers that prevent access to health services. And as you heard, these barriers can come in a number of shapes and forms, gender, socioeconomic, geographic, racial, and other age and others. And so from the U.S. government standpoint, how do we address these barriers? Well, earlier this year, we announced that we were increasing our partnerships with countries on global health security. We went from 26 partner countries to over 50 partner countries. And in doing so, we have taken an approach for equity and pandemic preparedness. And the partnership with them is increasing their capacity for global health security in 5 technical areas to get them to what's called demonstrated capacity, or essentially a level 4 on a 5-point scale. And in doing this, there are a couple of things to note. So women comprise the majority of the 600 million livestock keepers. And so when you think about animal health programs, you have to take a gendered approach to meet those women where they are and help them in their livestock keeper roles. Also, women are typically on the front lines when you think about healthcare workers. And we must then consider a gendered approach when we think about infection prevention and control, and also biosafety. And further, nurses comprise a large portion of healthcare workers. And typically nurses, or a lot of nurses, are women. And so one of the things that PEPFAR has done is it has launched a nursing leadership initiative, which seeks to enhance nursing practices, all in service of meeting the HIV goals that we have, but also protecting nurses, again, who are on the front lines, by strengthening and increasing infection prevention and control. So on the question of, are we farther away or are we closer? Excuse me, I'm not sick, but I do have a lingering cough from last week that I'll try to keep under control. So on this question, I do think, similar to the comments that you heard, I do think we are closer to achieving equity in global health security and strengthening global health security. If you look at that arc, that global health security arc or line of progression over the last 10 years, I think you can look at it through a couple of different lenses, or maybe 3 different lenses: financing, capacities that have been built, and then political will. And across all 3 of those, I think we are seeing an increase in the scholarship around those, including the Global Health Security conference that was hosted earlier this year in Australia, which I was just so impressed to see the scholarship there. It's the first time I had attended that. Also, the disciplines, we heard from President Gilliam the need for a multidisciplinary approach, and from Nahid, and then looking at people who are working in these areas across the career spectrum: early career, mid-career, later career. It's really incredible to see. So we've made a lot of progress. However, we do have a ways to go, and I think our work is getting more complex. It's getting more complex because there are things like the climate crisis that does a number of things, but excuse me, including increases the geographic distribution of vector-borne disease. There are things like mass movement of populations, which interrupts the access to and the delivery of healthcare services. There's also complex crises that are happening. This can be from natural disasters, political instability, conflict, or all of those things happening at once, which makes it harder to prevent, detect, and respond to infectious disease threats. And then also, it's getting harder to maintain that public information integrity because of misinformation, because of disinformation. So overall, our work is growing more complex, but I do agree with the sentiment that the trajectory is positive. Thank you.
Thank you for that, Hillary. Joia, I'm going to tease apart something you said, which is that epidemics and outbreaks affect our communities at known fault lines. And Craig, I'm so sorry, I'm going to bring you into this conversation for a
I
second.
was going to say, how come he's not up here?
He's not part of the conversation. Craig Spencer is a physician currently at Brown. He was working with MSF in 2014 Ebola virus disease epidemic, and was infected, was admitted to Bellevue. He speaks about it often, so I feel like I am able to talk about it. And the reason I'm bringing him up is Craig and I spent a day in Bellevue last week talking about 10-year anniversary of the 2014 Ebola virus disease epidemic. And the thing that came out in that conversation was so many emerging infectious diseases have this big confidence intervals when it comes to mortality statistics, right? Marburg could be 30% mortality, it could be 90% mortality. Ebola could be 15% mortality, it could be 90% mortality. And yes, huge part of that could be that we don't have like designated, targeted therapies for some of these diseases, but health systems is also a determinant of health, right? And what I wanted to ask is, you started talking about some of these health systems challenges. You talked about social challenges, but they're also specifically healthcare delivery and health systems challenges that serve as barriers to equity during epidemics. Can you build on that a little bit for those who may not understand that dynamic, and also reflect on whether they are integrated enough in international conversations when it comes to pandemic preparedness?
Yeah. Thank you. And thank you, Craig and Naheed. You guys were absolute heroes in that early days of the Ebola pandemic. So, look, I think that when we think about pandemic preparedness, we make a mistake thinking it is a punctuated thing. You know, you get a grant for pandemic preparedness. You get, and yet it's building over time the system that can then respond. And I mentioned Rwanda, but I'll mention some of our work in Sierra Leone. We responded to Ebola, and we did so, Partners in Health, at the request of the government. We didn't have a lot of expertise. We luckily pulled Naheed to teach us what to do. But we were among the only organizations that was willing to work with the government of Sierra Leone. They had no infrastructure whatsoever. They had no purpose-built facility. But their Sierra Leonean Ministry of Health colleagues were on the front line day in and day out with no PPE, no gloves, nothing. So we said, okay, we're gonna help you. We had decent outcomes. We didn't have the best outcomes. We had some infections, but the critique was, you know, we could do it better, but in the meantime, people are dying, you know, and I think that was a lesson that when the health system is so weak, when there's no IV fluids, when there's no blood pressure cuffs, when there's no electrolyte machines, it is very difficult to improve people's lives in a pandemic. It's kind of too late. I mean, like, you have to do it. But what we saw is, you know, we said, look, we're going to stay in Sierra Leone. We're not here for the pandemic, then we're leaving. We're going to stay in Sierra Leone. We're going to help, you know, rehabilitate a couple hospitals, a couple health centers, and try to make them decent and dignified and fit for the 21st century. So one thing we did, for example, was build an oxygen plant, because you can't really have a hospital without oxygen, it turns out. Putting in 24/7 electricity, which was not standard, right? And there are people who are saying, oh, but that's too much, it's not appropriate technology. It's really, how can you have a hospital without oxygen? Lo and behold, the next pandemic is COVID. And we were one of the only places that had oxygen in the entire country. And this is after money and people and effort pouring in for Ebola, but leaving very little because we're too focused, I think, sometimes on pandemics and not on the basic infrastructure you need. And Rwanda has really led the way. I mentioned Rwanda in my first comment, but Rwanda has been doing this systematically since HIV, using a lot of PEPFAR money, Global Fund money, saying, this is not about HIV for us. Our case-finding strategy is going to be a health system. Like, we're going to find HIV because people come to care. We're going to build decent primary care. We're going to try to improve hospitals. And so when you know, Ebola happened, they could isolate, quarantine, boom. when COVID happened, they had a stockpile of PCR tests in the country before we could even get regular testing in Boston. So, their goal is to build a system that can respond. And I think when we think of a pandemic as a disease, we make a mistake, rather thinking about the infrastructure we need. If you are fortunate enough to have Ebola and go to Bellevue Hospital, you're going to get care. But if you have Ebola and are going to go to a holding center in, some of the places they were telling people to go were like literally moribund, broken down schools, and telling people go there because then you won't spread it to others. Now, if it's your kid or your loved one, are you going to put them in some holding center with no medicines, no water, no food, no protection? Of course people don't go. And then there's this idea, well, people don't believe in Ebola. No, they don't believe in sticking their family members somewhere they're going to die. As soon as there was good care, we're inundated with people. So to me, leading with service, understanding that equity is about this fundamental right to health care, and then whatever we need to do with the pandemic is kind of gravy. But if you don't build a health system, then you're scrambling around trying to find oxygen for the next pandemic.
Yeah, it's funny you should say that. Virus, Rwanda's mortality is, 23%?
Yeah.
It is pretty incredible. Rwanda is a case in point of may not have everything under the face of the sun, but if you continue to build a system that the aim of which is equity, is responsiveness, is flexibility, that you can do that. Let me switch a little bit and talk to you, Andrea. You talked about the number of infectious diseases threats we've had and issues with equity here in the Americas. As we look to the next decade, what do you see as the most likely emerging infectious diseases threats? I think people in this audience may have been hearing, there's dengue outbreaks and there's chikungunya cases. What's up our alley in the next decade, and what are the strides that are being made to improve equity across the Americas? And then what are some of the barriers that remain there?
Yeah, no, thanks. I think, an important point is to look, if we look at the last 20, 25 years, is that major epidemics, that have occurred in our region, there were actually viruses that were imported. So I think, it's always very important to look at our region, and I'm definitely, in favor of, very much in favor of a regional prioritization of different pathogens, but we need as well to recognize that we cannot, we need to keep an eye on what's going on in other regions. Zika, chikungunya, basically, they were really coming from other region. And as I said before, for some reason, they really had a major impact in our regions that they didn't really have before, or was not observed before in other regions. So I think, that's really a manifestation, I think, of the inequity of the region. I think, really from an ecological point of view, if we look at the Americas, definitely, North America, it's actually a place, where there has been the emergence of many different pathogens. And I think we should not forget that. But of course, we deal more with Latin America and the Caribbean. And of course, there are two areas that are key. One is the Amazon basin, which for its ecology, for its variety of situation is really very important. And then, of course, the Darien Gap, this isthmus between Panama and South America, if you want, that as well. Two regions that are quite similar in terms of ecosystems that are really very diverse, sometimes, but really under a lot of stress, in terms of whether it is climate change, whether it is human activity, or whether, it's, and there are as well regions where, particularly the Amazon, it's where you have a quite dispersed population that have really difficult access to any type of healthcare. So this is definitely, two places, one place where we have, where we can see a lot. You find, so many different arboviruses, so many hemorrhagic fever viruses in these regions that it's really very important as well to do some sort of a systematic prioritization, which we have started doing. So there is not really, I don't want to name one specific virus or family, because it's really to look as well in terms of systematization, and we have really started doing that. Of note, I think, that it's kind of surprising to me that the really only autochthonous emerging pathogens that we have seen in the last 20 years, coming from the region, one is arguably influenza H1N1 in 2009, which we will not really think about as emerging pathogen, but it was, in a sense.
Very much so.
And the one more recent is actually Ropush. Ropush, that has always, caused over several decades, quite large outbreaks as well within the Amazon, but starting in late 2023, moved out from the Amazon into different Brazilian states that were not affected before, and of course more recently as well to Cuba. So, but we have as well evidence that it's not present in many other countries. In some countries present, but does not really cause outbreaks. So, I mean, it's really complicated sometimes.
For those who may not know about Ropucho, do you want to speak a little bit about the virus?
Yeah, it's basically, a virus that was always confined within the Amazonas. It has caused large outbreaks, even with tens of thousands of cases in sometimes. And it was very much linked to the destruction of the environment. Basically, when they started building as well highways within the Amazon, you had these different type of cases. It has always been considered, and we have not really, it was among the list of the possible viruses that could emerge, but it was not really recognized as being necessarily a virus that, it was very much like sick at the beginning, it's just, a fever, you will get over it. And now we are starting to recognize that maybe there are as well some implication of a vertical transmission, of course, very much like Zika, and as well what may actually be the neurological complication, in terms of Guillain-Barré syndrome or other type as well of neurological conditions that may actually be quite important. So. It's definitely a threat, and it's definitely as well a virus that it's changing. Like any virus that you give them the opportunity of transmitting, it will just change in that sense. No?
It also brings to mind that we so think of viruses either as human viruses or animal viruses, but increasingly nature is forcing us to say you have to live in a one health world because you live in a one health world, and everything we're doing is reflecting back to us in terms of risk as well.
Yeah.
I want to switch a little bit to you. Hillary, you talked about, both you and Joia talked about this a little bit, the idea of diagonal development, which is to use a disease-specific program to create capacity that's broader, that can actually be linked to future threats. No public health program, I think, maybe one of the best examples of this, by the way, in terms of public health programs that the US government has funded has been PEPFAR. Incredibly effective in bringing equity and access to antiretroviral therapies. How do you think about how either PEPFAR can be expanded to include pandemic preparedness or used as a model for future pandemic preparedness investments by the USG?
Yeah, well, thank you very much for this question. It's something that we are thinking about quite a lot. What are those linkages between PEPFAR and our broader global health security work? And I think Joia set the need for this up really well with her comments. So for those of you who have seen the U.S. Global Health Security Strategy, you'll see that Goal 2 talks about linkages between global health security and complementary programs, of which PEPFAR is one of those complementary programs. And I think from our perspective, we really see PEPFAR investments as strengthening global health security, and conversely, global health security investments as helping us to meet and deliver our broader global health goals, our development goals, our national security goals. And so they're really mutually reinforcing and mutually beneficial. So some of you may know, or many of you may know, that HIV was the first disease to be considered a global security threat. It was debated by the UN Security Council in the, I think, early 2000s or in 2000, and its impacts of it were So there's really been links between HIV and global health security for 20 plus years now. PEPFAR's mission is to end HIV as a public health threat by 2030, while sustainably strengthening public health systems. And PEPFAR has remained very laser focused on the prevention, care, and treatment of HIV, and in doing so has supported dozens of countries to increase access to health care, which has also strengthened pandemic preparedness and response in the process. And these investments really, while focused on HIV, and that is their congressional purpose, have had a dual purpose of strengthening global health security capacities, including on diagnostics, high quality diagnostics, surveillance, and then also on building healthcare and health system infrastructure that can be leveraged more broadly for global health security. PEPFAR has also contributed to the resilience of health systems. You heard me talk about climate impacts and other impacts. PEPFAR, in countries where PEPFAR is active, there have been cyclones, there's been political instability, there's been conflict, and it's really that those lessons learned have served to build more resilient health systems overall. And there have been recent examples of PEPFAR contributing to outbreak response, COVID-19, Ebola, Marburg, and of course Mpox. And generally, when this happens, when PEPFAR contributes to outbreak response, it is because PEPFAR has worked with national authorities to leverage the PEPFAR-supported health systems. This can be human resources, it can be the lab systems, it can be waste management, diagnostic platforms we heard Joia talk about as well, supply chains, and data systems. Data systems are also really important. And to do so in a way that does not negatively impact the HIV activities and the HIV purpose of those resources. I think this is best documented for COVID-19, where PEPFAR investments were leveraged for COVID for diagnostic capacities, laboratory infrastructure and systems, and then also the national health systems, the information systems, I should say. And additionally, during Mpox, we saw that PEPFAR had access to key populations who were disproportionately affected by Mpox and was effective in ensuring that those populations had access to testing and also information about Mpox and how to keep themselves safe. So, in summary, PEPFAR has contributed really substantially to global health security. There is more work to do here. There are more lessons to be learned from it, and there's more linkages to be made. But I think we have a really good foundation.
Yeah, you can't say this, but I will say this. It was a program created under a Republican president. So it's actually just responsible leadership rather than administrations that count. And so hopefully we can continue to build great in public health infrastructure over the next 4 years as well. I'm going to talk a little bit about this idea of how we use exemplars. You and I were just having a conversation, Joia, right before this started about Richard Cash, who recently passed away. He was a public health professor at Harvard, and Paul, and this idea of, Partners in Health mission is creating these incredible exemplars of being able to provide equitable primary care and good clinical, high-level technical, clinical care that can improve and show that you can improve outcomes of health even in resource-limited settings. And Richard's lifelong passion had been how we use low-cost interventions to reach the most amount of possible people to save the most amount of lives. Usually there's not a conflict between those two missions, but there's only so much limited money, right? How do you use exemplars? How do you use centers of excellence or countries that do excellent work like Rwanda? How do you use those examples to create overall, capacity, improve broader impacts? How do we use the multiplier effect here to meet both Paul's mission and Richard's mission? The easiest question of the night.
I think prevention and treatment absolutely go hand in hand. And I think in my training in public health, it was in the era that prevention and kind of the utilitarian ethic that you do the greatest good for the greatest number of people was, was the norm. That's what we were taught in schools of public health. I think the AIDS epidemic and activism is what upended that. I think, AIDS activists around the world said, there is a treatment and we have a right to that treatment. And meanwhile, paper after paper was being published on this prevention and that prevention. And by the way, at the time, you couldn't even measure prevention anyway. And so I think there is a part of security or a part of health, health system strengthening wasn't even a thing. That, if you look in the literature, that idea of health system strengthening occurred because we won the fight for HIV treatment access, and to do that, you needed labs and people and what we say, staff, space, system, social support. You gotta put that all in there. And so, I always say, nobody gave us a bunch of AIDS medicines. We took it with a wheelbarrow and dumped it in a village and said, figure it out. No, you have to really put together the systems. And so I think the false dichotomy is really false, because I saw it with my own eyes as HIV provider in Haiti in the late 90s. We had tests. Nobody wanted to get tested until there was treatment. Once there was treatment, then people wanted to get tests. And then after having this debate year after year that prevention was more effective than treatment, we actually found out that treatment was also prevention. And the change in the epidemic that Hillary's talking about is going to happen because we have 32 million people on HIV treatment. So I think we made a mistake in really separating these things, because the real exemplars are countries that have put this together as a comprehensive system. And rather than look at security against a disease, look at what is the thing we need to build for healthcare as a basic human right, and then how does that need to morph and change if we have a new threat. And so, I think our greatest privilege at Partners in Health is we work with countries, because most countries want people to be healthy. That's not all countries, but most public servants really want to do their job. And so the exemplars are just getting the money and the resources and the capacities into the hands of people who want to do the right thing, and then trying to lay that out. And of course, good political will, I think, is the most important thing, and we see that in certain, not only countries like Rwanda, but certain districts. You can always find somebody who's who really wants to do the right thing. So I think putting the exemplar idea is putting it all together. It's not separating out pieces.
So switching a little bit to that, right? So we achieve equity with the technologies we have here at hand, Andrea, right? But it seems like we're making, advances left and right. AI, CRISPR, mRNA vaccines is creating new frontiers of inequity, right? What are some of these technologies that you think we're going to be seeing where equity is going to be an important part, and how do we ensure that we, even as we're trying to catch up on some of the health systems aspects, that we don't fall behind on new things that are coming down the pipe?
No, and I think, thank you for mentioning Richard Cash, because I think, if you think, in terms of what we with Dr. Nadil as well, he developed in terms of the oral rehydration solution or ORS, that are such a staple, nowadays in terms of the, treating cholera and as well other diarrheal diseases, estimated, to having saved over 50 million lives, mainly in children as well, Yes, it's low tech, but, if you are in the midst of an outbreak, your first responsibility as well is always to save lives. So it's not, you treat. You have to have something to treat, and you have to do that. That doesn't take away, that you need as well to have surveillance, diagnostic, understanding, how your outbreak is moving, who is at a greater risk in terms of communication, et cetera, to prevent further cases, But it's definitely, a combination of the two. And when you're responding when you move from preparedness, obviously, to response is because something you were not able to prevent something. So you switch to response, and anything you have at disposition, you definitely need to use. But I think there are some, and I go back again to the idea that an innovation, a piece of technology, however great it is, if it is not put into a system that can actually make the best of it, is not very much useful. No? MR and vaccine, or another novel vaccine platform, they are great technology. I think they're really game changer in a way. But if they are not really within, if you don't have strong immunization systems, in normal time, you are not gonna build, the capacity to vaccinate millions of people, from one day to the other one. So that's definitely a very important part of it. The other part, I think, that it's as well in terms of the importance of things that maybe we don't perceive as being technologies, like, the use of vaccines, of immunization, it's really a pity, all the misinformation, disinformation around of them. We don't really see that in terms of a technology, a new technology, how we actually approach and how we can actually protect, restore as well the vaccine confidence. But in my mind, it's very much an innovation, how we need to go about, how we need to leverage social sciences as well in terms of creating as well the capacity for us to preserve that, that tremendous public health goods that is immunization and vaccine. So not necessarily, technology is something that it comes from the technical part, but it needs as well to come more from other aspects in that sense.
So implementation sciences, potentially, and communications and behavior sciences.
Definitely. I mean, we need to have a, very strong health system. That's for sure. I mean, that's the base for everything. Really, the best response you have to prepare it in what we call always peacetime, but I don't like too much the term because it seems that then we are going to go to war at some time, which is not either the good part. But definitely, you need to have good system, in the inter-epidemic phase. But then as well, when you switch to response, you need as well to have to be very flexible and to be able to put together as well different type of many different aspects of that.
Yeah. Hilary, can I switch to? So we talked a little bit about the micro perspective on the clinical bedside. We talked a little bit about regional readiness. Could you talk a little bit about what USG's role and responsibility in ensuring equity, pandemic preparedness, global health security is, and how do we meet those programmatic goals and aspirations in the setting of potentially lower congressional funding in the last few years on that topic?
Yeah, thank you for this question. So I like to think that the U.S. government is a leader in equity across the board, but including in pandemic preparedness and response. Maybe one other example drawing from PEPFAR to share. So PEPFAR has a long-standing practice legacy even of following the data and using that to change or modify the programming, and following the science, of course, is important in that as well. In its most recent strategy, PEPFAR recognized closing equity gaps as a key barrier to meeting its goals at the time for 2025 and also for 2030. And in particular, these equity gaps were seen amongst key populations, children, and also adolescent girls and young women. And specifically in 2022, new infections, HIV infections, were highest among the age groups of 15 to 24 and also 25 to 34 females. With males, that doubles the male counterparts in those age groups. So quite a difference there. On the therapy side, on the treatment side, while it has improved since 2010, there are still gaps that PEPFAR is seen in pregnant people, which is so critical in preventing that mother-to-child transmission or vertical transmission. And further, there are inequities that they're seeing across the board for children. And PEPFAR is trying to address these inequities and close these equity gaps head on. In particular, they launched a new initiative called Safe Births, Healthy Babies, which is a 2-year, $40 million effort to eliminate mother-to-child transmission of HIV, focused particularly in those high-burden HIV countries. Another way, and a different way, that we are doing this, particularly as you noted in resource-constrained settings, is leveraging multilateral funds. So, as I mentioned, I'm at the State Department. The head of our bureau is Ambassador John Kengasong. He's the Global AIDS Coordinator for the U.S. government. He holds 2 board seats. Work closely with Assistant Secretary Pace for both the Global Fund against AIDS, TB, and malaria, and also the Pandemic Fund. And using these multilateral funds, the U.S. is able to pledge and then leverage our contribution to bring other donors to the table, donors that otherwise maybe wouldn't have contributed. In particular, for the Global Fund during the last replenishment, we pledged up to $6 billion. And for the Pandemic Fund, pledged, this was just recently in the last couple of months, pledged up to $667 million. And by we have a congressional limitation that we can provide up to 1/3 of the total pledging goal, and it allows us to take our pledge to other countries, other philanthropies, the private sector even, and say, this is what we're bringing to the table, what can you bring to the table, so that we're increasing that overall pie for the mandates of the Pandemic Fund and of the Global Fund. So it's been really effective. And just maybe one note on the Pandemic Fund, it's a relatively new fund in case you aren't so familiar with it. It was established in 2022 and it's focused on, of course, pandemic preparedness. It's had awarded nearly $900 million in grants so far, so since its inception. And the really great thing about the Pandemic Fund is that for every $1 in Pandemic Fund grant money, it mobilizes another $6 in other financing from multilateral development banks, domestic financing, private sector, and other. So it's really seen as seed funding to increase that broader funding pie and financing for pandemic preparedness.
Yeah, I have a bunch of other questions, but I feel like there's one that I really want to get to and then open it up to Q&A. So I'm going to do that so that we can give it a chance for our audience to ask these questions. And feel free to either address this question or not. Public health is always political. It's always been political. You know, science has always been political. The minute you start telling people the Earth is not the middle of the universe, you know, it's political. But things are very polarized right now, even as political things go, right? Public health has become polarized. How do we argue for greater support of vulnerable communities, both within our borders here in the United States and across the globe? How do we argue for that equity, you know, in pandemic preparedness in this environment? What are some effective ways forward? Andrea, I'll have you go first.
Yes. No, this day, you know, I was thinking about the way we communicate in general, you know, because I think we must obviously stick to the evidence, and it's, and you know, as well in academia, you know, what you produce, but we are not always very good in terms of communicating the evidence. And so I think, you know, it's not necessarily communication that is targeted to decision makers or, you know, or important people. I think, you know, we really need to do a lot better job in terms of communicating in general to the public. No? And, you know, I remember in my experience, for instance, back during the COVID-19 pandemic, something that was extremely useful to me was actually listening to a podcast that was produced by Dr. Christian Dorsten from the Charity Hospital in Germany. It was a good opportunity to brush up my German, but it was as well really very nice because you had over a episode of 1 hour, there was really the opportunity of actually going into quite in detail, but as well in a very, very good in terms of communicating, about the evidence that was being produced. So for me, it was really a wonderful way, to keep up to the evidence, but at the same time as well understand, how I had to communicate with my same colleagues, because sometimes you think that your colleagues, they understand, but they don't. And so that idea of being able as well of translating evidence in a way that communications that, your colleagues understand, your family understand, is something that you actually create a coalition, I think, that goes beyond, not only targeting some specific decision makers. So the idea is that we can really get free of these ideas that we communicate by sound bites, but we create really opportunity to kind of spread the message in a way, spread the evidence, but in a way as well that can reach, a lot of people. I think it's a really important one, I guess.
Joia, what do you think?
I'm going to pass to Hillary.
Oh, I don't know. You go ahead, Hillary. Yeah.
Well, maybe not directly responsive
Yes.
to your question, but I did want to insert into this conversation the importance of community leadership and having community leadership for our purposes in the PEPFAR program, and then also in the national government that we're partnering with, so that those voices are heard, that ownership is there, and that communities are part of the decision making, which ultimately leads to sustainability of the work and better outcomes, shared outcomes, and achieving our goals of global health and global health security.
Thank you for that. All right, opening it up to the room, and then also, Cassandra, if we have any questions online. Yeah. We have a question back there. Cassandra's going to get a mic for you.
Sorry, who was raising their hand? Hi, I'm currently a student at SPHABU, but I was wondering, how do you address a historical bias, especially with younger generations? Because something I have come to find out, especially as I learn the history of public health, is there's a lot of things I'll never see in my lifetime, and I'm very thankful for that. But it also means we kind of have this, or I've seen a lack of urgency with responses to disease. So when you hear the outbreak of polio, people are like, well, we have vaccines for that. But it's like, this wrecked generations, right? There was a time when parents wouldn't let their kids go eat ice cream because they thought it caused polio, and it wasn't that, but people carry that through like their stories and their history. How do you address those issues when there's countries that still have that on like the front of their, I guess, not so distant history, and then places like the United States where when we mention death by measles or polio, we say that's our great-grandparents, we say that's our great-great-grandparents, because I think that's something in particular I've just always kind of wondered, especially now as I'm getting ready to be an adult in the public health field.
Great question.
Awesome question. I think, how does public health escape the curse of its own success in some ways, where people have forgotten, well, what were threats? What do you guys think?
I mean, I think it's a wonderful question. Thank you for asking that. I would say one of the things, taking off a bit what Hillary said, I think hearing from people, like not staying too much in our ivory tower and hearing from people who are affected. Some of the most powerful people I know who've taught me so much are, Ebola survivors or people who've had tuberculosis, people who've had HIV. My own uncle had polio. And so I think trying to remember that the position that we sit in, if you've had higher education, you are in this rarefied atmosphere, and even in our own country, the people who suffer from diseases, like they may have nothing in common with us. So really trying to, as much as we can, like hear from people who have suffer. Often I talk about, like, for example, maternal mortality, not an infectious disease. And if I'm talking to our team in Haiti and say, how many of you know a woman who's died in childbirth, everybody's hand goes up. But here, it's a rarity. So I think trying to make sure that if we're dealing with health, that we are talking to people who are not advantaged with all of these things and trying to understand that. I don't know, getting our education somewhere a little bit outside the ivory tower if we can.
I would just add, and also it's a really fantastic question. So, and we're seeing this a little bit with HIV and with the PEPFAR program, because the program has been so successful in many countries, but in particular some, it's no longer a concern for some of the political leadership.
Yeah.
And so my colleagues who work on PEPFAR have had a concerted effort to engage the political leadership to say, this is still a challenge. This is something you have to pay attention to. The gains that we've made are so fragile. Within 30 days of going off of treatment, people could transmit the virus or, potentially have really bad outcomes. So that is something that we are doing with high-level political dialogues, for example, on the margins of the UN General Assembly, which was in New York in September. There was a particular dialogue focused on the sustainability of HIV programs, but really fantastic question.
I think we have a question online.
Yeah, the online audience is very engaged. We have a few questions, but one of them was going back to what Joia was saying about the lack of interest in testing with HIV and how that has the interest in communication. They were asking, did this contribute to the lack of interest in testing for COVID at the beginning of the pandemic? Sure. And how do you think public health needs to do a better job helping communities to understand all components of disease prevention, which includes preventative transmission measures?
I think that was a question for you.
Okay. I think that it is important to offer people something. Right? Surveillance can seem very uncomfortable, and public health has a history in surveillance, which is not great, right? And so I think to do a good job at getting people tested, raising awareness, we have to have something to provide to people, whether it's some social support, whether it's a vaccine, whether it's a treatment, because I don't think, people in general don't like being surveilled. And I think whenever we think of a strategy, it really has to have, a person-centered approach. What is that person, how are they gonna benefit? How is this gonna help their life? And I think that really changes the dynamic a lot.
If I may add a point, maybe that many times, during this type of situation, we actually have kind of a short window of opportunity where we can actually use a technology, or where there is actually demand for a technology. If you were mentioning the question, the issue of testing, really in many places at the beginning of the pandemic, there was not really testing available. And I think, that could have really been a moment where testing was actually critical. The same with vaccine, at the beginning in Latin America, for instance, there was a big willingness actually to get vaccinated. When the vaccines were available, that window of opportunity was actually in part gone. So I think, that's really what preparedness is. Preparedness is really when you think carefully, what may be some critical tools that you will need, and that you are prepared actually to face, that situation, and maybe adapting, what you have in terms of testing. For instance, PCR testing, you can adapt it quite relatively easy, to a new pathogens, and so it's actually available. It may not be at scale, but it can really be at certain point, something that is very, very important, as well in terms of what you are giving, to the people and population in that sense.
Thank you. Questions? I see a few. Okay, we got Dr. Spencer.
Thank you. Thank you all for this. I have millions of questions, but I will focus on equity and pandemics. I vacillate between being a realist and an angry activist. And I'm curious your thoughts on lenacapavir, the twice yearly injection that can like dramatically decrease new HIV infections. And Gilead did a great thing by expanding access to low-income countries, but at the same time, there's still a lot of people that are not going to have access, and there wasn't really an effort to build up, production capacity in a lot of places. How are you thinking about this as realists, as activists, and is there a way to kind of bridge that gap?
I mean, I think it's a great question. I do think that the voluntary kind of corporate responsibility is not scalable. I mean, I think that we saw that with COVAX, right? Like, the goal was let's get, people to donate, countries to donate their vaccine so that we can reach maybe 20%. And it failed 100%. I mean, and so I think it's great that Gilead did that, but I think if we want that drug and similar drugs to be in the pipeline, they have to get on the essential drug. I mean, like, we kind of know what to do, right? They need to get on the essential drug list. They need to be manufactured generically. They need to be we need to work with the partners who would, be paying for them, whether it's the USG or, UNICEF or whatever. So I think that sometimes, and that is the delay, right? That's the delay, because it is great when, you look at drugs for hepatitis C, we still, even in this country, everybody doesn't have access because they're so expensive. I was talking to a guy who runs, prisons health in Illinois. So we can't get everybody treated for hepatitis C. So I think the plan has to be, when we have a plan for scale, it has to really start with what do we need, and then how do we do it from the bottom up? How do we actually, what are the steps that have to happen? Because I think if you just put something out and make it available without a real plan, it doesn't have legs. I think that's what happened in COVID vaccine.
Can I comment on that,
Yeah.
Craig? This is definitely true. I think having products but not having a plan, you need to have the plan. Often also what happens is people say, well, there's no demand for this. So why do you want us to spend all this money and create a manufacturing plant somewhere else? Not realizing that availability actually creates demand. A plan
It's supply
creates,
side.
it creates
side.
demand,
Yes.
right? Aside from the things that Joia wisely talked about, which were the idea of generics, presence of generics, the medicine patent pools, let's played a role in some areas. Oftentimes we think of delivery of some of these drugs at the tail end, once they're made, and we don't think at the beginning part. I actually just gave a lecture, and Adam's class was sitting behind you on Tuesday, and I said this, which I said, we think about equity as how many of these doses and how fast, and that's really important. Those contracts get made way before drugs are done. So some of our CEPI colleagues are actually online, so this is going to be a shout out to them. One of the ways that the Coalition for Epidemic Prevention and Innovation has done this is when they make contracts with new companies for drugs for pandemic preparedness tools, they introduce the idea of delivery by a certain time. That was the issue with COVAX, right? The vaccines were there, they just didn't make it there in time. They also introduced the idea of a certain amount of what's being produced is going to be shared. Other things that people may not think about that are critically important in terms of equity for each of these different kinds of products is that we don't put enough time into target product profiles. We only make drugs that are going to work from a really well-resourced healthcare system, which is not going to play out. That is a lack of equity to begin with. It's in the architecture. And the other part that I think that often gets missed, aside from target product profile, is ensuring that it is again, as I said at the very beginning, we're treating endemic diseases and not just the ones that matter to us. And that part is part of research at the very beginning as well. But there's a question back there. Yeah.
Thank you very much for the insightful discussions. Joy mentioned that pandemic preparedness should be building over time. And one of the reports that came out from the COVID-19 pandemic was that there was a lot of fragmentation with governance and coordination. And so I'm wondering, would there be any benefit in having a unified governance structure or framework that could like guide nations or countries in preparing for and responding to future pandemics? Thank you.
Yeah, I'm smiling because I think Assistant Secretary Pace is going to talk about the Pandemic Accord, international health regulations. That might help address some of that questions. But
Nice.
any comments from the panel?
I would just say, I'll let you address the Pandemic Accord, which I think is very responsive to your question. But also there's other forums I think that are important. One that the State Department has put forward is a foreign ministry channel for health security. It's a forum that is dedicated to foreign ministries, recognizing that technical cooperation, conversations between CDC and others must continue, but we also need foreign ministries, political level leadership to talk during health emergencies, but also, you know, in those periods, not too many of them now, when we don't have a health emergency ongoing. So we've established and launched this channel. It's discussed issues such as AMR, the Mpox response, One Health, training diplomats on health security, because that is, you know, a competency that is becoming more and more important. And so just that, some people call it plurilateral, but just that forum, I think is really critical in addition to what I think you're referencing, which is the kind of more big multilateral process.
I think we're running over, but if there's like one quick question, I think, yeah, sorry, Adam.
Okay, I also think I have a billion questions, being an infectious diseases practicing clinicians trained at Boston Medical Center. Is there a standard operating procedure? I hear the Mpox response currently, and access to vaccines where they're needed right now. As I'm hearing rumors about need for boosters, which I can imagine they'll only be available in countries that are better resourced. So speaking of equity and pandemic preparedness, I was just curious if you have thoughts about where we are with getting vaccines right now in Africa where they're needed for Mpox clade 1 infections. Thank you.
Anybody?
We don't have it. We do not have it. So there is no standard operating procedure. And, you know, I think that is something we have to do, and is just, the trickle down is so slow. And, you know, there has to be more recognition that, you know, we're all in this together. But I think, unfortunately, as Nahid said, you know, if we don't feel that it's a threat to us, somehow we're not that invested in it. So I think, yeah, Mpox is an example. COVID-19 was an example. Yeah, people are not getting the vaccines. I teach graduate school at Harvard Medical School. My students are from all over the world, and I always start my class on equity by saying, how many people got Sinopharm and Sinovax? And all the students from Asia raise their hand. And the Americans are like, what? Who? You know, okay, how many people got Sputnik, right? You know, even within this is so fragmented. How many people got nothing until they came to the US and they had to get a vaccine, right? So it really is so fragmented. There's no standard operating procedures, even in the setting of a massive global pandemic.
Andrea, do you want to? Yeah, and then Hillary.
Just a couple of points. Maybe I don't like too much the idea of standard procedures, you know, in terms of responding or preparing to epidemics, because we do planning, and then, you know, you are faced with realities that it's always a little bit different. So you need really to be able to adapt and move out from, you know, what may be really something that is too strict or too established in that sense. So I think, you know, that's one part. Definitely, you know, the allocation of very scarce resources on the global market, it's a need. And I think, you know, and there is not really an easy formula in that sense. You know, for instance, you know, we feel that at the region of the America, in terms of the distribution of the COVID vaccine, was actually, if we look, in terms as well as incidence, it was not really a fair distribution in that sense. No? So it's really a complicated issue, the part of allocation. And as well, right now, in terms of mpox, definitely there is that thing. But there is really this expectation as well of that we solve the issue with donation from countries to other countries, and usually from the north into the southern hemisphere. And to me, that's not a solution. I mean, it's really just, a band-aid to something that we really never really were able to fix, in a sense. So I think, now the expectation is really there is a plan how to respond to mpox in Africa in particular, but it's really based as well on the donation of vaccines. So I think, that's, to me, is really a major limitation in a sense.
Quick note, Hillary, last word.
Just quickly, so maybe coming back to where we started, that the trajectory is positive. We still have a lot of work to do. For mpox in particular, there are countries that are donating vaccines in support. The U.S. has donated or pledged to donate up to 1 million vaccines, $500 million to support the mpox response. But there's still a lot to be worked out in allocation, and maybe Assistant Secretary Pace will say more about that. Yeah.
All right, with that, can we give our panel a big applause? Thank you so much. So we're going to take not a 10-minute, but a 5-minute, so you're able to go and walk around. But before you do, I wanted to just share with you a very quick 2-minute video about a new program we're launching here at the Center on Emerging Infectious Diseases called Biothreats Emergence Analysis and Communications Network. We talked a little bit about not knowing how we're going to battle new threats when not everybody in the world knows at the same time when a threat has occurred, when that communication needs to be there. Could we go to the next slide? I'm realizing there's no keyboard here. And can you hit play? Thank you. And I would ask you to kindly come back. Thank you so much. All right, and I am going to, it truly is an honor to introduce our keynote speaker for tonight, who I got to watch in action from my role at the White House COVID response team. Just Ms. Loyce Pace, Assistant Secretary Loyce Pace, is someone who speaks speaks the equity talk, but she walks it. Every event I've seen her speak in, she comes in with passion, with compassion, with true understanding of what it means to be a global citizen and to be able to bring about change in a honorable and sustainable fashion. So with that, I'm going to introduce Assistant Secretary for Global Affairs at the U.S. Department of Health and Human Services. Ms. Pace is responsible for advancing the United States international agenda through multilateral, bilateral forums, reporting directly to the Secretary of the HHS. She's the Office of Global Affairs lead on setting priorities and policies that promote American public health agencies' interests worldwide. Ms. Pace oversees HHS's engagement with foreign governments and international institutions, as well as policymaking bodies such as the G7, the G20, United Nations General Assembly, the World Health Assembly. Previously, she served as the President and Executive Director of Global Health Council and was also a member of the Biden-Harris Transition COVID-19 Advisory Board. At GHC, she advocated for increased federal investments in global health in the face of budget cuts to the U.S. CDC, the U.S. USAID, and WHO. Ms. Pace holds a bachelor with honors in human biology from Stanford and a master's degree in international affairs, international health, and human rights with the distinction of Delta Omega from Johns Hopkins Bloomberg School of Public Health. And with that, Assistant Secretary Pace.
Thanks, Steph. Appreciate you. Hi, y'all. Hi. Exhale. It's been a week, hasn't it? I can say things Hillary can't, so I can say things like that. Listen, this is, I've been repeating a mantra in my head the past couple of days, I guess is all it's been, space and grace. So if you all would offer me some space and grace today, I would very much appreciate it, partly because this is my first time in front of people since Tuesday. And so it really means a lot, what you said, Nahid, about how you see me showing up. I show up for you and everyone here and there, online, wherever you are. You all have kept me honest these now 4 years that I've been in this role or leading up to this role. And I see Craig, I see Joia, I see others who were there when I was named to the COVID transition or the transition COVID board pretty much 4 years ago. And that was a big time. It was an important time for us to show up in what we felt would be the right way, or at least a better way, not just for the US, but for the world. So y'all can let me know how it's gone. But, let's have a conversation about that. I think now is a good time to reflect, and especially, I don't think any of us here can forecast where we're going, but I think we need to, speak frankly about what the road ahead could look like. But before I get there, as I already said, a lot's happened this week, but not just the obvious stuff. Also what's happened this past week is I have been on phone calls with folks inside and outside government, with folks in the community, but in particular with government stakeholders in other countries about outbreaks and things that continue to, I won't say plague us, but keep our attention. Things going on around the world, whether that's with Marburg and what Rwanda is able to do and what they might need from countries like the US, but importantly, other partners in the region and elsewhere in their Marburg response or outbreak response, to the DRC or other countries like Uganda battling mpox and Clade 1 in particular. So thank you very much for asking this question. That continues to be an ongoing conversation. And I think it's important for people to realize how we spend our time, how we spend our days. And it hasn't just been the past month or week, right? It's been the past year that we've anticipated these outbreaks or emergencies emerging. And it's a bad thing that's happening, of course, but it's a good thing that it didn't catch us completely off guard. And it's an even better thing that we have a plan, we know what to do when it happens, because that's the point. And speaking of what comes next, I think it's our hope that we can continue to exercise that muscle, if not strengthen it. Something else I did this week, or this past week, was I was down in Rio for, as you do, down in Rio. But don't worry, it was just 30 hours, and I think I saw the beach but didn't visit it. But I was there for the G20 Health Ministerial. That's also a place where we come together and talk about some of these same issues. I applaud Brazil for putting this on. It's really hard to put on these conversations in a way that feels meaningful to everyone. And they're pretty stacked up, knowing they're going to host the climate conference and the BRICS conference in the next year. But in any case, pandemics and global health security and global health preparedness remain front and center on our agenda. And that's difficult, increasingly difficult. I think Dr. Carter might have mentioned this, right? I mean, people have been talking about pandemics for so long that it is difficult for us, I think, to continue to have the policy conversation and certainly to have the public conversation. But we were having the conversation, which is important. And even on the sidelines, right? I'm talking to folks from the UK who had their first imported case of Mpox clade 1b, and asking us, or telling us sort of how they're approaching things. Or we're talking to the government of Brazil about Oropouche and what they're facing currently. We are sharing our experience with H5N1, because let's not forget, the US is facing our own situation now as this virus continues to, or the how this virus is showing up in the States might be different, and we need to be paying attention to that. So we have this shared responsibility to come together and have these conversations, and that's been important to keep in mind. The other thing happening this week, and next week for that matter, are the negotiations in Geneva around a pandemic agreement, accord, call it by many names, just don't call it a treaty. At least not in the United States. But in any case, there are these conversations happening, and we know, I think it was already said, maybe by Dr. Vicari, that we haven't gotten as far as we wanted to or needed to. But we meaning USG and other parts of the world, remain at the table in a really important way. So all this is just, not even the past 7 days, right? If you can believe it. And yet, that's what's taken up my time, in addition to other major events. But when it comes to, where we've landed now in terms of who will be in my seat come next year, I think it's fair to ask some questions like, okay, are we going to be focused on donating doses, if at all, right? Or are we going to contract and focus more on domestic availability and supply? Are we going to cooperate with other countries if and when we see something or they see something and want to say something, or are we going to close our borders? Are we going to focus and continue to invest in global or regional production of innovations, which is frankly what the US has been doing, in case you didn't know, in South Africa, in India, in other parts of the world? Or are we going to hold tightly to patents that can save lives? I'll make sure people know that perhaps it came later than it should have, but we made sure that in this administration we did share COVID technology. And even if that wasn't something that companies in other parts of the world could draw from at the time, we felt like it was an important signal or precedent to set. And we learned from the HIV/AIDS crisis, frankly, and shame of not doing that for a decade. And we didn't want we didn't want to never share it, and we certainly didn't want to wait 10 years to share it. But these are now the questions, I think, that are front and center for me and front and center for I think, many stakeholders. So I don't know. I don't know what the answers to those questions are, and I don't know what the future holds. But I can talk about our past, our immediate past, and the legacy that that presents, potentially. I'll start by, I think Hillary did a great job not just talking about global health security, but our investments in global health and how that those have been leveraged for what we face today and every day. Since 2021, the U.S. has committed, invested close to $50 billion in global health. It's a lot. And it's important to keep in mind how forward-leaning this country continues to be, even at a hard time, right? Even throughout COVID and just given the economic downturns, the ways other countries were pulling back or questioning whether they could show up in the same way, we continued to push. And we invested essentially in everything we could, right? We didn't see these as trade-offs between WHO or the Global Fund, right? Or between research or response. We want to do it all because we believe in a both-and strategy. And we've been able to do that, speaking of both-and, not only in sort of discrete, concrete initiatives like AIDS or malaria or tuberculosis, but we've invested in health systems, we've invested in the workforce, and we believe very strongly in how we lift up. We have Assistant Administrator Gawande talk about primary health care. We have, obviously, Ambassador Nkengasong talk a lot about how we leverage PEPFAR and how PEPFAR has done so much to enhance systems and surveillance in countries. Our CDC director speaks to that and sees that firsthand as well. So those investments have been key for us. We also, though, just coming down to sort of what people are seeking, I think, from us and maybe even seeing in the face of outbreaks, is we've been able to provide doses to the world to the degree that countries have not yet been able to manufacture, invest in those facilities, or recruit people to do that work, let alone set up regulatory systems and other important elements to be sure they can produce or manufacture drugs and vaccines. We've provided those, hundreds of millions of doses, even for Mpox. And that's something that I know Hillary mentioned towards the end of the last session, but it's important to keep in mind because some of these drugs, they weren't even made necessarily for, or they're not necessarily approved directly for things like Mpox and Marburg, and yet the US is pulling from our emergency stockpiles and saying, well, what is this for if we can't protect Americans by protecting the world? So we've made that case internally, and we're trying to practice what we preach. And these aren't easy conversations, right? Because there's a very knee-jerk reaction to seeing all of this as a trade-off, and maybe it arguably is. But there's also this question of whether we pay now or pay later, right? And there are consequences to any decision. And I think we tried to be really quite responsible, learning from COVID-19 and other circumstances, right? SARS and others, to say, well, where do we want to be in this moment? And where do we need to be in this moment? Where does the world need us to be? Another, I'll count it as a win, right? Put it in that column. But another really important effort we undertook in this administration, and this isn't meant to be a commercial, but hey, you got me, so. But we were able to update the very wonky sounding international health regulations. I'm sure everybody in this room knows what I'm talking about, which is great, because when I talk to my mom about it, she's like, I'm half asleep, but say more. And we know, if we're paying attention to the international health regulations, that they're not perfect. We've had to update them a couple of other times. But in this latest stretch, heck, the last time we looked at these, we didn't have, or we weren't using the internet in the same way. We didn't have social media, right? So that alone, just how we communicate with one another and what we expect of other countries or parties to the international health regulations, in terms of how rapidly something is communicated and what is actually shared is critically important, we learned. We learned that in COVID, and we were learning it real time every day. But we've also looked at, as part of this IHR improvement process, we've looked at where countries are in their readiness, right? Or where parties are in their readiness. And we've talked about the strengthening of systems or building of capacities so that they can kind of meet these elevated requirements, if you will, of the IHRs. And then importantly, there's a critical role not just for the parties to the international health regulations, but obviously for WHO as sort of the host of all of us when it comes to these conversations, these commitments. And that's been controversial, surprisingly, right? Whether or not we empower the World Health Organization and to what degree. I think I would argue here, and something I've said down in Washington is, well, goodness, I mean, do we want a weak WHO who can't respond to health emergencies, who can't hold countries accountable? Obviously, governments are sovereign and they do what they want, right? But if there are no rules, then I worry a lot about what we're able to do, not just in global health, but pretty much in anything else. So those are some things that we focused on, and I mention all of those because I think there's an important, well, I won't just say that. Every time we talked about each of those efforts, we started with equity. When you talk about availability of innovations, that's an equity proposition, like Dr. Mukherjee was saying, right? When you talk about sharing of information and data, and even the impact or consequences of sharing that information or data, that's an equity question or consideration. And there, I think the other way that we've talked about equity, and hopefully have demonstrated equity, is by what we choose to focus on and how we choose to approach it. One sort of mantra I have around equity is, and this is, now this is a bad word, right? But equity starts with inclusion. It has to. I mean, you can't do anything for anyone without knowing what it is they really want and how they themselves would approach these problems. And this is even more important in a world where we are not sure where countries like the US are going to be at any particular time. And there arguably has been an over-reliance on the Western world, for better or worse, for resources, sure, but also for presence and participation, let alone our own responsibility. And those things we know even just from our immediate past history aren't certain. So I think former President Obama had it right when he said, okay, when he worked with staff, of course, but he said, okay, let's, in the wake of Ebola, the West Africa Ebola outbreak a decade ago, let's set up the global health security agenda. Let's have some sort of forum or initiative whereby it's not just the US in the driver's seat, but we pull, sure, we can facilitate these things, but the world comes together around these questions and problems and helps each other, right? And this is something that we've been able to even build on in the wake of COVID. One area that's new for the global health security agenda is something called legal preparedness. Another wonky term, right? Why do we care about legal preparedness? Well, turns out when you have new vaccines, there are a lot of questions about these new vaccines. And perhaps not every country around the world has approved these vaccines because maybe they don't have regulatory authorities like the FDA to do that. And even if the WHO has done that, there are still some questions about, well, what happens if people, have some side effects or adverse outcomes, right? There's a whole liability question. You need a lot of lawyers around the table to figure that out. And it turns out plenty of countries don't have that architecture or infrastructure to do that. So in addition to talking about data sharing, right, or surveillance, in addition to talking about how we build out the workforce, or protect that workforce, frankly, in their response, we had to talk about the legal stuff, right, and the logistical stuff. So that has been a really important lesson learned for us in the expansion of the problem, but again, who sits at the table to identify and solve that problem. I think we've also been able to demonstrate that through the ways we've lifted up regional bodies like the Africa CDC. You know, little known secret, maybe a well-known secret in this crowd. The US had a lot to do with Africa CDC. We don't talk about that a lot because we actually surprisingly don't need to take credit for everything. And it was really important, I think, for the architects and the original backers of Africa CDC that it wasn't seen as the US driving everything. That ownership really needed to sit in the region, and the region absolutely owns Africa CDC. It has been elevated under the African Union. We've been able to expand our partnership with them and sign a broader memorandum of cooperation that doesn't just sit with our CDC in the US, but is reaching the Bureau at the Department of State and other parts of the US government. And that's important because, again, these institutions, these initiatives need to survive with or without us. And we've been able to support similar efforts in regions like Southeast Asia, right, through their ASEAN network, and in other really important ways. And that's, again, I think, a testament to pulling other people in and, you know, leading from behind, if you will. I think another way, and I'll just mention this briefly because we talked about it a bit already. Another win for us, as we see it, is the launch of this pandemic fund, and especially at a time when I think the global health community and maybe the greater world was asking, can we do more, or do we need more, right? The reason the pandemic fund is so important, I think everyone knows here, is it's not a response fund, right? It's that, maybe I don't call it a peacetime fund, right? But it's when things are kind of at a lull and it's like, oh wait, now we can focus on like how we strategically build things out so that we can actually be resilient when it hits the fan. And I know we're grateful that people came along with the US in this idea, right? In trying to build up something that would be good, not just for us, but for the world. We're not quite there yet. In terms of getting money in that kitty, but at least we have that piggy bank, and that thermometer is rising in ways that have already proved valuable, frankly, with the projects we're seeing and with the partnerships that have been formed. So where does that put us? I think, you know, just sticking with this theme of who's out front and who's at the table, the trend line is continuing to move in this direction. Perhaps by necessity at this point. I'm still processing the events of this week. But as we're sitting in Geneva, as we're sitting in Rio, as we're sitting in other places and spaces, I have increasingly gotten the question, what happens if you all aren't here, for us and with us? And honestly, I think it's been less of a question in recent weeks or days, and it's been more of a statement. We have to be ready for whatever is what the world is saying. And I personally would agree. I would hope and believe that our legacy as leaders in this space is sound, and we've observed that, we've experienced that for decades across administrations and leadership. But, the world deserves to set their own table and to drive this or have different drivers of this agenda too. And I think, we saw this in COVID. We saw it when we all couldn't show up for each other in the same way and things were flattened, literally. But, new leaders or different models or exemplars, I think was the term used earlier, emerged by necessity. What do we learn or do from that? How do we move forward, given those examples, or given that potential constraint? I'm sorry, I'm afraid I'm bringing the room down. Don't worry, we can have fun. Now, I think one real outstanding question I'll come back to, and partly because it was a question, is how we make it stick. I think our government has tried to, and perhaps accomplished, doing quite a bit in terms of equity, but I'm worried that it perhaps has come across as too transactional or ad hoc. So okay, mpox response, great, let's get on it. COVID response, let's get on it. But I think there's a question back here which asks, well, how do we ensure that we don't have to sort of build the plane every time we want to go flying? That, arguably, has been the purpose of the pandemic accord and those negotiations. And it's one of the reasons why the U.S. has been at that table, too, because we believe in the long game, right? This is not just about sort of the banner things that we do, put it on a plane, slap on a flag, yay. No. This is about the boring stuff happening in Geneva. Nobody cares, right? Some people care. Some people care a lot. I get a lot of emails. But, you would never know how much good it's potentially doing to have some international consensus around things like vaccine sharing, let alone vaccine allocation or, the research or regulatory framework or everything you can imagine has been part of these conversations. There are still sticking points that were outlined already. And so there's real worry that we might not get where we need to be. But for now, frankly, we are still very much at the table, which is a good thing. The final question, I would say, is whether we remain at the table. It's a big question, and I just figured there are all kinds of elephants in this room. I'm just pointing to all of them. You're welcome. But there was a lot of stuff that we did on time in this administration, and I credit our colleagues who were who were the day one people who came in and said, let's get her done. Let's launch this fund. let's have this summit and set this standard. I'm looking at you, Beth Cameron, if you're watching, right? But there are people who really drove home the need to re-engage with WHO and do that meaningfully in health security, but broadly, the need to set up an Office of Pandemics at the White House and reestablish that, right? Those were year one, year two things. It took us, longer to get the IHRs done, understandably so. And it's taking us even longer to get this pandemic accord done. And now, I think there's some hand-wringing about whether we've taken too long. We collectively, this is not just on the US, right? And for what it's worth, we really tried to seal this deal back in the spring for World Health Assembly. But the deal isn't done. And I wonder aloud what it looks like to end up without a deal or have something that doesn't include the US government. These are big questions to which I don't have answers, again, to be clear. There's also a big question about our relationships around the world, including in global health, and in particular with the World Health Organization. Folks might remember my face from when I had a lot of things to say about whether or not we participate in WHO. And I stand by the importance of working with WHO, flaws and all. And this administration has been very clear about improving WHO, but remaining at the table for perhaps obvious reasons. But what happens now, right? What happens with their resourcing? What happens with their membership or mandate? WHO has rightfully, I would say, twinned the issue of climate and health, particularly with regards to One Health, but even more broadly. Pollution, fires, famine, floods. They've come to understand and better articulate the intersection of gender and health. But these now are not things that everyone wants them talking about or doing. So what happens now with that engagement? And then I'm so glad that the panel talked about information. And of course, that can be as basic as how information flows, right, in an outbreak or emergency. But the value and validity of information cannot be stressed enough. And what happens now to science? It's not hyperbolic to ask this question, particularly in a US context. Partly because we've been here before. So, you know, I suppose a better question is how we respond in the event things teeter in directions that are not going to serve us and our work and the people we're trying to serve through our work. I think there are a lot of folks who can make a strong case for collaboration versus isolation. And I hope that those people make that case. And I hope that those people include our partners who have lived through the value of US engagement and leadership, or at least partnership. I don't know what's coming, but I do know that we have a plan and a path to continue making progress. And I hope and pray, frankly, that whoever comes after me and us will use it. Thanks.
Couple of questions?
Yes, I'll take questions. No,
All right.
I'm leaving, no questions. No, just kidding.
Questions from the audience, either in person or online. Rob, we're getting a mic too.
Assistant Secretary, so when you walk into a party filled with congressional people, who comes over to you and talks to you about things? And,
No names. No, this is a great question.
but is there a type of you know, congressperson who engages with you and listens to what you're thinking?
No, it's a really great question. There are, I think Dr. Carter touched a little bit on this in that there's been a lot of transition on the Hill. And 20 years, you know, we can't believe we've been at this for 2 and 3 decades, some of us more. But yeah, there's, you know, you look up and a lot of your friends are gone. But there are people who, you know, still care about this issue and who are still tracking it. There are people who are, and they're not just on like the health committees, right? Interestingly, and perhaps not apparent to folks up here, you have your foreign affairs folks, and global health sits in that bucket largely, but you have domestic health folks who, especially in the wake of COVID, are like, wait a minute, we should actually care about global health. What is going on, in fact? Oh, you have people in China? Great, can we talk to them? Usually the answer is no, but there are other folks who are focused in region. And so we were talking about Latin America earlier. Obviously, there are folks focused on Asia, on the African continent. And so they will come at this in a certain way or as well, especially given the intersection of health with with like the fabric of society. And I have to give credit to, of course, yes, I'm willing and ready to talk to just about any congressional member. Many of them are my neighbors at home. But the staff, it's really the staff we rely on to track this. And so, you know, if you're at a party, I would find the 20-something, if not 30-something, who is tagging along with the elected official, because that person really can track what you're saying and doing, and will follow up. Mm-hmm.
Other questions? Joia, and then Adam. Oh, Adam, definitely you.
Exactly.
Yeah, go to Adam first.
Yeah, hi. Adam Cameron Scott from Fletcher School of Law and Diplomacy. I understand we're all... I've been in contact with a few prominent global health leaders in the wake of Tuesday. And the concern is, particularly around the Accord, is that now it's dead. One person even used a whole bunch of not emoji symbols, but all the yeah.
Was there a skull involved?
As in substitution for an expletive. I guess what you've outlined is 100% accurate in that we don't really know what's coming ahead. But I guess particularly when we're looking at pandemic response and global equity and health security, what are our other options to progress this outside of an agreement? Because if that doesn't happen, like there's been so much hope that's been placed on this, what happens if that doesn't happen?
So, some good news. When we shared COVID vaccines with the world, we documented how we shared COVID vaccines with the world. And that was built on previous iterations of sharing products. We didn't have to do it at such a wide scale previously, which is why it needed to be updated. But even as we're working towards getting these up to 1 million mpox vaccines out, that's another lesson, right? Especially when it comes to, some of the regulatory barriers, with things that are approved differently, yada, yada. So, it's not perfect, but it's a potential placeholder for a still pending accord to say, well, we don't, just because we haven't agreed on a global mechanism, the U.S. has a position and a policy on this stuff. And we've been able to do this in the absence of an accord the past 3-4 years, right? So why not now? I would also, look, let's give a lot of credit to non-governmental stakeholders in this moment, at every moment. I mean, that's my old world and next world, presumably. But, the work is happening, surely alongside and along with USG, but it's particularly outside of USG. So, I think especially when we think about research, but even, if we think more broadly about that system strengthening, whether it's academia, whether it's industry, and I'm talking about manufacturing, I'm talking about workforce development, I'm talking about, a lot of important things, mis and disinformation, heck, the ways we were able to work with multiple industries, multiple sectors to react or respond, let alone prepare and mitigate some of this in the future, that's going to be critical. And I think, what we saw 5 years ago, is we saw those non-governmental actors really step into the space that had been left, perhaps, in the absence of government action. I hope that helps.
Joia?
That's kind of more or less what
We have an online question.
Kind of building off that same question. If starting next year, government channels and involvement change, which channels should public health professionals take to keep communication open with global partners?
Yeah. These, I think, so first I should say, don't give up just yet on Washington. I know that's asking a lot. But it's government is big, whether folks, want it to be or not. And there are a lot of folks who carry over, who have really important and helpful institutional memory, and who, not everyone will remain because, everyone's tired of all the things, but many will. And so that they can continue to be resources potentially. And then these sort of non-US driven or led initiatives, including the Pandemic Fund, frankly, but, GHSA and other efforts, those are fair game, right? You have Ethiopia leading the Global Health Security Agenda this year. You have the co-chairs of the Pandemic Fund, Rwanda and Indonesia, if I'm not mistaken, right? And these folks will turn over, but my point is, if these aren't relationships folks have already, they should absolutely establish them. And some direct connection in the way that we saw Partners in Health do so well. Always, MSF has done that well, right? Let's take advantage of the world of global health being more open to other actors, and build those bridges differently.
Any last question? Can I ask a question?
Yes.
What gives you hope to keep going?
You already almost brought me to tears when you started, and so you're not allowed to bring me to tears as we're ending. What gives me hope is, I mean this sincerely, and obviously not planned, is being on this campus, is sitting in a room with people who are like, hey, I'm just starting out, and it might sound cliche, and I don't care. But there's still people who want to do this work. There's still people who want to do this work, even though we've known about some of these diseases for 50, 100 years in some cases, and we still haven't gotten there, you know? Or even though government officials like me get nasty grams from folks, and folks step down or otherwise step away, even though it feels as though there are powerful forces against us, people are still showing up. Yeah. And the days when I have to sit down, as demonstrated by how I am on the stage, are the days, that I can see someone else walking by me, and even if I can't get up and walk with them, I know once I stand up and start walking again, that there's someone I can walk towards who is paving the way.
Cannot think of better words to end this. Thank you so much.